let's wrap up Unit 8 with evaluating these psychotherapies that we had just talked about. So who do people turn to when they are in a mental health crisis or have psychological difficulties? Well, it's kind of a toss-up between physicians and mental health specialists, but community health mental health specialists are the people who provide the largest outpatient psychotherapy. So these are clinicians that are going to be providing therapy to people who do not stay overnight at an institution. Physicians are going to be providing the drug therapy. Mental health specialists a lot of times are going to be doing that outpatient therapy. Which psychotherapy is used the most? By far, cognitive therapy, and probably because of what cognitive therapy is used to treat. It's used to treat anxiety and depression, and a lot of those are the highest disorders or the highest prevalence of disorders, followed by the psychoanalytic or psychodynamic therapies, as well as family and group therapies. So a lot of the success of therapy is going to be based on the client's as well as the clinician's perception of the therapy. If the client or the clinician believe that this therapy is beneficial, then it will be beneficial. It's kind of like the placebo effect, but we can't really say that because it's not proven that it's working. But a lot of the success of the therapy comes from whether or not that client believes it is helping. And sometimes clients actually overestimate the effectiveness of the therapy. Some critics might say that the clients could just subside, that crisis might subside over time. Maybe the clients just need to believe that the therapy was worth the effort. And then maybe they just, like their therapist since they don't want to say that it didn't work. And then clinicians as well. Clinicians believe that therapy is a success. Why would they not? I mean, it's their job. They believe that the client is better off receiving the therapy than not receiving the therapy at all. And if there are failures, they believe that they come from other clinicians sometimes. So if a client decides to go seek another clinician, or if they are coming from another clinician, the formal therapist is likely to argue that the client has developed something else, that they need extra additional help. Also, clinicians are likely to testify the efficacy of their therapy regardless of the outcome. So they're going to say that the treatment works whether or not it actually did well for that particular person. But we do know that 2/3 of clients improve after seeking therapy, or whether or not they receive therapy. And so Einsick went and did a meta-analysis, which is looking at a whole bunch of different studies and then comparing them. And what he found is that 2/3 of clients will improve whether or not they receive therapy. However, we have a ton more studies now than Einsick did at the time. Mary Lee Smith in 1980 analyzed 475 different studies and showed that average therapy clients end up better off than 80% of untreated individuals on the waiting list. So you're 80% better off than someone who did not receive therapy. And in general, those not undergoing therapy do improve. However, those undergoing therapy are more likely to improve. That's kind of the idea, that your diagnosis will improve over time. However, if you don't seek treatment, you're not as likely to improve. Okay, so which therapy is most effective? Well, it depends on the disorder that you're treating. Depression is treated best with behavior, cognitive, and interpersonal therapies. Anxiety with cognition, exposure, and stress inoculation. Bulimia is cognitive behavioral therapy. Phobia, behavior, and not just behavior, but exposure therapy. Bedwetting would be behavior modification. And so these are all different types of therapies that are going to be treated depending on the disorder that that person has. So which one is best? Well, no one type of therapy has been found to be superior to the others. It really just depends on finding that right course of treatment for that particular person and what works best for them. A lot of psychotherapists, however, are striving to tailor specific treatments to specific problems so there can be an easier pathway. However, again, it really just depends on that person and what is going to work best for that person. So let's talk about some alternative therapies. Therapeutic touch is basically massage where therapists move their hands a few inches from the client's body, sometimes touching certain parts of the body. We have seen that this does not really work. Eye movement, desensitization, and reprocessing. This is having people move their eyes back and forth while remembering traumatic experiences. Again, has not really seemed to work that great. Light exposure therapy is used to treat seasonal affective disorder, which is a form of depression that happens during the winter months for a lot of people where they can't go outside, there's not as much sunlight, and so they feel down or depressed. And this has actually been effectively treated by light exposure therapy, and it's been scientifically validated. Basically, the person is going to be exposed to vitamin D, the light, or light that would be kind of like sunlight. So what type of therapists do we have? Well, we have clinical psychologists. Clinical psychologists are mostly going to have PhDs. These are going to be people who are experts in research, assessment, and therapy, and they have been supervised during an internship. We have clinical or psychiatric social workers. These people usually have a master's in social work plus postgraduate supervision internships, which prepares them to sometimes offer psychotherapy, mostly to people with everyday problems, not necessarily psychological disorders. Then we have counselors. A lot of times these are pastoral counselors, like a priest or a pastor. There's abuse counselors who work specifically with people who have suffered from abuse, and then substance abuse counselors, and so on and so forth. And then we have psychiatrists. Psychiatrists are physicians. They have their MD, and they specialize in the treatment of psychological disorders. So not all psychiatrists have had extensive training in psychotherapy, but they do have their MDs, so they can prescribe medication. Okay, so they don't necessarily perform psychotherapies, but they do provide the prescribed medication. The best thing to do, however, than treating a psychological disorder is to prevent a psychological disorder. So preventing means removing the factors that affect society. So if we can fix things like poverty, less work or less stressful work, removing criticism, unemployment, racism, and sexism, we can lower the prevalence of psychological disorders. Some advocates of preventative mental health programs argue that many psychological disorders really are due to those social conditions in which people live. And if we want to prevent these disorders, we need to change the oppressive environments into more benevolent or nurturing environments that will foster individual growth and self-confidence. And like we've said before, disorders are biopsychosocial in nature. There is not one thing that causes these psychological disorders. They come from all ranges, which means that we need to intervene on both the biological, psychological, and sociocultural levels. So the biological levels would be meaning using drug therapy, electroconvulsive therapy, psychosurgery sometimes, and this would help a patient. But we also need to intervene with therapy, and then in addition, learning to help these oppressive situations for people, and in order to fix the society's problems so people aren't in the oppressive situations.